So let's go ahead and begin chapter 26. Let me just make sure that. Cool. Yeah, so let's go ahead and begin talking about repair and regeneration within the nervous system. And there's three major things that we're going to be talking about. We're going to be discussing the type of repair mechanisms that you find within the peripheral nervous system, the type of repair that you find within the central nervous system, and then we're going to very briefly mention stem cells as well. But in reality, like the most effective type of neuroregeneration will take place in the peripheral nervous system. The central nervous system doesn't really regenerate, unfortunately. So once you get damage to the central nervous system, more than likely you're going to start seeing like scar tissue development. Whereas with peripheral nerve damage, you can actually see full nerve regeneration, where you can regain sensory perception as well as motor function. So we'll talk about that process in a little bit momentarily. So here's an overview of all the stuff we're going to be discussing. We're going to talk about some of the effects of strokes, right, affecting the central nervous system. We're going to talk about peripheral nerve regeneration, including Dr. Henry Head, who's a pretty wild dude. He self-inflicted a nerve injury so that he could see what the actual regeneration process would look like. So he took self-experimentation to a whole different level. Pretty amazing stuff, which also segues into the mechanisms of Wallerian generation, which was described by another physician later on. We're going to talk about muscle reinnervation, because that can happen too, where if you sever a motor neuron, you can actually see regeneration of those nerve fibers. Also, central nervous system regeneration. We're going to talk about the type of injuries, some things that we've already talked about already, like stroke, for example, hypoxic injury. But we're going to talk very briefly about TBE, or CTE, chronic traumatic encephalopathy. And you can, I miswrote that. So it's instead of TB, it's chronic traumatic encephalopathy. It's CTE. I miswrote it in the lecture notes. So we'll talk about that in a second. And then we're going to briefly talk about stem cells and also some interesting studies that they did using radioisotopes of carbon during like nuclear testing and whatnot to see actually how nerves potentially regenerate within the central nervous system. So we'll talk about that in a second. So here are some of the things that limit nerves from regenerating. First of all, nerves, as we already talked about quite a bit this semester, they're postmitotic, right? Once they establish their mature form, they're not going to change much at all. And so that's one of the main things that contributes to the limiting factors on neural regeneration. This you'll see predominantly in the central nervous system, whereas in the peripheral nervous system, you can see more regeneration taking place. One of the main exceptions within the central nervous system is going to be within the hippocampus, as well as within the olfactory bulb. So within the olfactory bulb, you're seeing lots of nerves like regenerating and new nerves being formed, especially interneurons. And so that allows you to, basically like, be able to like discover new senses of smell and new like chemical, like for example, like people who train for maybe like wine, like sommeliers, right? They're training their nose to be able to pick up on aromas that most people, don't really pick up on. But because you're able to like train those neurons, you can see regeneration within the olfactory bulb. And then the hippocampus, of course, because you're forming new memories all the time, right? So you see a lot of neuroplasticity as well as neuroregeneration within the hippocampus. But other than that, you're not really seeing much. So neurons are postmitotic. Neurons have to have connection with each other, right? Remember we talked about how if neurons do not communicate with each other, at least in synchronicity, you're going to see weakened signals being pruned back, right? Those synapses that are weak are not going to be strengthened, whereas the synapses that are constantly firing, constantly communicating, those are going to be strengthened. And then one of the big things here with the central nervous system is you're going to see scar tissue formation. And that's going to be predominantly mediated by glial tissue. So all the supportive cells like astrocytes, microglia, all those types of cells are going to be coming into play when you have a central nervous system injury. And then as a consequence, you're going to see scar tissue formation. So that's one of the reasons why strokes are so impairing, right? Once you get damage to the central nervous system, you're not really going to see much in terms of neuroregeneration. So, neurodegenerative diseases disrupt neural function at the molecular levels. So we've talked about a couple of these already. We're going to get more into Parkinson's and Huntington's when we start discussing motor function, especially with the basal ganglia. So we're going to go into that later. We're going to talk briefly about Alzheimer's today. I think probably our last lecture is going to be where we talk about Alzheimer's in more detail, because we're going to talk a little bit about cognitive psychology, cognitive neuroscience, which Alzheimer's definitely comes into play there. ALS, which we already discussed, right, which affects both upper and lower motor neurons. These are all diseases that affect the central nervous system. And on top of that, these diseases also have a genetic basis to them. So genes come into play, like for example with Alzheimer's, the ApoE4 mutation. That's one of the types of like genetic mutations that really increases the risk of developing Alzheimer's in life. What else? Individuals with trisomy 21, right? Down syndrome patients, they have a higher propensity of developing Alzheimer's. So a lot of these diseases have a genetic basis to them. So here are some of the things that you might see on microscopy. This, especially with Alzheimer's, you're going to see amyloid plaques as well as neurofibrillary tangles. I am going to say a little caveat, though, with amyloid plaques. There's an interesting article. I haven't got a chance to read the whole entire thing through yet, but the studies that were done on amyloid plaque discovery, this is about 15 years ago, a lot of neuroscientists have had a hard time replicating those studies. So it might be possible that amyloid plaques are not exactly like the full picture when it comes to Alzheimer's. It might be incidental, but who knows? I think it's a possibility that some of those original studies might have been a little bit exaggerated. Yeah.
Is that the thing that's like, it's actually tau? Never mind. It's right there.
Yeah. So amyloid plaques, neurofibrillary tangles, that's going to be your tau proteins. And amyloid plaques are going to interfere with the ability for axons to propagate a signal, right? So you do find those in, neurodegenerative conditions, but is it truly like the actual thing that's causing the Alzheimer's symptoms to manifest? It's, I think more studies are going to be done on that coming up, because it's an interesting study that came out recently disputing amyloid plaques in Alzheimer's. But regardless, for the sake of this class, amyloid plaques, neurofibrillary tangles, those are going to be hallmarks of Alzheimer's. And we're going to discuss tau protein when it comes to chronic traumatic encephalopathy, CTE. And so you're going to see different temporal changes over time after an injury. So when you have an injury in the short term, you're going to see deficits in the short term, after the injury. But then in the medium to long term, you can actually see parts of the brain trying to compensate for what was lost. And so you're going to see increased activation in certain regions to try to compensate. And over time, as the motor function returns, post stroke, for example, you're going to see those areas reduce in activation. They're going to kind of go back to a baseline. But in the immediate aftermath of an injury, you're going to see a lot of activity in those brain regions. So here's a really good summary of all those findings. So first you get focal activity in the hands representing focal activity representation in the brain is going to increase after a stroke, for example. So that means that those regions in the brain are trying to become more activated so they can try to compensate for what was lost. Over time, you're going to start seeing improvement of the function, for example, what was lost, maybe hand movement in this example. And then that focal activity that's represented in those regions of the brain eventually dissipate, right, as things kind of return back to normal. That's because of all the compensatory mechanisms came into play, and now the person was able to actually recover and see some improvement in function. So here's after a pontine stroke. Over time, you're going to see increased recovery score. That's, especially with rehabilitation, patients who get a stroke, they're going to go into physical rehabilitation, right? Physical therapy. And the whole purpose of physical therapy is trying to recover what was lost, right? And it's possible to get quite a bit of recovery, depending on the severity of the stroke. If it's a really, really bad, severe stroke, the recovery is not going to be that great. But if it's not as severe and you can actually get physical therapy that can address those functions that are lost, you could see improvement over time. So here's, this is a composite image. So this is a composite of a patient over a period of time where you can see different degrees of activation in different parts of the brain. So the red areas are where you see loss of function, and then the green areas are where you're seeing increased activity. And in those areas, you're trying, the brain is basically trying to recover what was lost. Other things that can be done in terms of like clinical interventions, you could do electrical stimulation of neurons. So in this case, this is an epidural electrical stimulator, right, where they put in like an electrode where they're stimulating the neuron so they can try to maintain neuronal firing. Because whenever you have an injury to a neuron, the distal portion, at the the area downstream from the injury is still there, right? And you can still stimulate that neuron. And so you can still try to regain some function after an injury. So here's a little video on electrical stimulation. Let me turn this up a little bit. It's so quiet.
To understand how epidural stimulation works. In a simple way, electrical stimuli will activate fibers and neurons within the spinal cord, and therefore then these structures produce stimuli sending to periphery, muscles, blood vessels, which eventually result to the stimuli applied to the spinal cord. Epidural stimulation produces more physiological response. It activates motor neurons within the spinal cord, which will send signal to the muscle, and muscle will contract. Functional electrical stimulation, electrode positions directly in the muscle or above the muscle, and functional electrical stimulation produces direct activation of the muscle. In order to improve motor function after the long period of paralysis, patient should expect that with epidural stimulation, even there is a restoration of voluntary movement, but person have to go back to retrain his lower limbs to ambulate properly, to coordinate movements again, and that's why this is what expected. We do know from the previous history of implantation of epidural stimulation for the pain management, it's a safe procedure.
I think the surgery itself is about an hour and a half tops, and then they spend a little bit of time looking at the placement and all that. So I think you're in for about just over 3+ hours. Yeah, it was a little bit of the unknown, but knowing that it was cutting edge and an opportunity to get some sort of movement back, it was borderline emotional. I mean, you haven't seen those movements for, in my case, 4 years, and all of a sudden now you're seeing that, and again, your mind starts to go, wow, how far can this go, right? So yeah, it was great.
I know that majority of my patients, and this is known from other studies, what is number one priority for recovery? It's not actually ambulation, it's a recovery of autonomic dysfunctions.
Bladder was really good improvement right at the beginning. It's kind of tapered off a little bit. Bowel was much better improved off the beginning and stayed consistent all the way through. If you've got to spend an hour and a half in the bathroom in the morning, well, you cut it back your day out just that much more. So if now you can do that in 20 minutes, well, it's another hour in bed. So that's probably the hidden benefit to it, right?
Although epidural stimulation showed very interesting effects on motor function, autonomic functions after spinal injury, we have to be cautious. We are only at the beginning of understanding what this therapy can result. We still have to investigate what is the long-term effects of this therapy as well.
I think nobody wants to be told that, hey, you have this, or this has happened to you, and there's no advancement. So just get used to where you are, and people want to think that there's an opportunity, there's some hope, and have realistic expectations, but never give up on hope.
So pretty cool stuff. It's really, really cool. And then the other idea with this too is that you have to have those types of treatments coupled with exercise. Right? I'm going to show you an image in a little bit from your textbook from a study that was done showing that with mice models where they actually engaged in exercise after a nerve injury, peripheral nerve damage, that you can actually see better recovery of those areas that were affected. So super cool. Again, local reflex circuitry, sensory afferents, and the connections with interneurons in the ventral horn, all that remains intact after you have nerve damage, right? And so the idea behind doing this type of stimulatory recovery process is to basically allow for continual stimulation of those regions. So you might be able to regain a little bit of motor function over time. And this is for areas around where it was affected, right? Yeah. So this is actually the spinal cord too. They literally put the electrode on the spinal cord. So that's why it's called epidural nerve stimulation. So you're literally stimulating the spinal cord, but those pathways are still present. This unfortunately is going to be much better for crushing type injuries, right? And so crushing type injuries are going to respond a little bit better to these types of interventions. Injuries that involve complete severing of the neurons are going to be a little bit more difficult to treat. So here are the three major types of repairs that we're going to go into. So spontaneous axon regeneration. This has to do with the peripheral nervous system. So this is PNS. Repair and regrowth of damaged neurons that involves things like astrocytes, glial scar. That's CNS. So that's going to be central nervous system. And this number 2 here is really not that great. Number 1, spontaneous nerve regrowth. Right? We're going to talk about Wallerian degeneration in a little bit. That's peripheral nervous system, and that's going to be much more effective. And then you also have stem cells that are being, more widely embraced and used in research and whatnot. So stem cells, which would form neuroblasts, which can form new neurons, that's a way that you can get nerve regeneration as well. There's actually some studies that show that you have certain animals, for example, have stem cells in their eyes, and so they're able to actually regenerate rods, but not cones, which we'll talk about later on. So that's a growing area of interest. So here's peripheral nerve regeneration. So you have post injuries, as long as you still have communication between the distal portion and the proximal portion, so long as there's a little bit of communication between those areas, you can get regeneration of those neurons. They sometimes can even do interventions where they go in and do grafting procedures, or they can put in these, a bridge, an artificial bridge that basically allows the distal and the proximal ends to maintain communication so that they can regenerate. But yeah, the idea behind peripheral nerve regeneration is that you can actually get basically full function returning. Central nerve regeneration, not as great. So you have glial cells, which are just kind of hanging out, right? These are your supportive cells in your central nervous system. Once you have the injury, those glial cells basically become activated. And then after you have all the repair mechanisms coming into play, then you're going to see a lot of scar tissue building up in those areas. So not great. You also have a lot of inflammatory cells that come in, especially if you disrupt the blood-brain barrier. You're going to get neutrophils, lymphocytes coming in, and those can really increase a lot of inflammation in the brain. So not great. And then you have stem cell replacement. right? So stem cells, you got neural stem cells. They're gonna, eventually regenerate new neurons. So they can also make connections with other neurons that are in the proximity to those new cells. So let's focus now on peripheral nerve regeneration. And so this is basically all I'm going to test you guys on for this next exam, is peripheral nerve regeneration. Because in reality, it's one of the only types of nerve regeneration processes that happen naturally that can actually, allow for full recovery. So this guy, Dr. Henry Head, like I said earlier, crazy dude. He did these nerve regeneration studies on himself. He literally had his radial nerve in his arm surgically transected so he could see what the process of healing would look like. He did, actually. Yeah, it took about 2 to 6 months. So it did heal. But if you read up on him, which I recommend you doing because he's a weirdo, very controversial. Even at that time, it was super controversial. People criticized him for what he did. Right? This is crazy to do that kind of thing to yourself. But I don't know, pretty amazing stuff. He's got more nerves than I do. So this is what happened. So you literally transected the radial nerve, and then there was an area that was affected. Right, he no longer was able to feel sensation in certain regions of his arm. And over time, he was able to eventually regain function of those areas. So this is photographs of his arm, and he drew these little areas on his hand to indicate which areas were completely numb. So all these areas over here were completely numb on the medial. That's the lateral forearm, right? And so this was insensitive to painful stimuli like pinprick, for example, as well as even gentle touch, right, with a cotton swab. So these areas were completely like no sensation. Over time, this is what happened to his hand. It eventually started to get better. And so he did these little stipple type marks, these little dots. Those were areas that indicated hot and cold, areas that were more sensitive than before. And so he eventually was able to regain a lot of function. And so that was the study of Dr. Henry Head. And then you have another doctor that came in, Augustus Waller, and he was a neurophysiologist. Dr. Henry Head was a actual neurologist practicing in England. And then you had Dr. Waller, who came in, who actually discovered the actual mechanism behind peripheral nerve regeneration. And so we call this Wallerian degeneration. Why is it called degeneration? Is because you have degeneration of the Schwann cells that are in place, but then they eventually get replaced by new Schwann cells in the peripheral nerve system. And so these are the cells that are involved in peripheral nerve regeneration. So this is Wallerian degeneration. Schwann cells, fibroblasts, macrophages, as well as epithelial cells. So those are the 4 major cell types that you guys should be familiar with. So what's Wallerian degeneration? Well-orchestrated morphologic and biochemical change that occurs in the axon, Schwann cells, and macrophages distal to the site of nerve injury, resulting in the establishment of a microenvironment supportive of axonal regeneration. So it's degeneration insofar as the Schwann cells that were previously there get degenerated, but then you also have a scaffolding in place that allows for new Schwann cells to develop new myelin sheaths, and then also just the formation of the remaining portions of the actual axon itself. So this is peripheral nerve regeneration. Again, it involves macrophages. Macrophages basically come in and they clean out all the debris. Schwann cells start to multiply, right? So long as they're still connected, you got to have a bridge. They have to sort of still be in contact with each other. If you have complete severance, complete breakage, you're not going to get this process taking place. You need to have at least a little bit of scaffolding in place for this to take place. So if the nerves do find each other, that's when you actually see repair coming into play. Within the nervous system, you don't really get, within the central nervous system, you're not getting this process. Astrocytes and the glial cells basically just wreak havoc, and they form way too much scar tissue for regeneration to take place. So this is only a phenomenon within the peripheral nervous system. So here's your neuron. You got your axon. all of a sudden you get trauma, right? The trauma, you get breakage of the axon. Macrophages are going to come in to help clean up all that debris. The Schwann cells that used to form the myelin sheath, they eventually degenerate. Then you start seeing new Schwann cells come into play. So it's basically laying down a scaffold through which a new axon can basically regenerate. And so now you're able to reestablish those connections. And that involves a lot of different biochemical processes, like a lot of different trophic factors, transcription factors, lots of different things come into play with this whole process. So it's super cool stuff. So here's your nerve tube, which is part of the whole perineurium. Again, the distal portion is what degenerates. That's why it's called Wallerian degeneration. The proximal axon is going to also create a growth cone. Right? Remember when we had growth cones, when we discussed like lamellipodia, right, filopodia, and all that stuff. Right? So you get that whole process coming into play here as well. And then here's an image that was taken of a live mouse where you could see the nerve was able to regenerate after being severed, right? And so this is especially something that you will see more effective. This process is more effective in more like crushing type injuries. You can see it in cut injuries as well, but it's a little bit tougher to regenerate. So it really depends on the actual like severity of the injury. So again, macrophages clear up the debris, Schwann cells are going to proliferate, you get genetic expression, right? Different transcription factors come into play. Also a lot of different receptors, which I'm not going to test you guys on. I'm not going to test you on the different receptors that are involved in this process, but there's quite a few of them. And then you get single transduction as well. And so here's that nerve bridge. Again, you have to have the distal and the proximal areas like at least coming into contact with each other so you can form that neuronal bridge. Otherwise, you're not going to get this process. Other cells that might come into play too, you might see neutrophils coming into play as well. But the main ones are going to be macrophages, fibroblasts, endothelial cells, and Schwann cells. And this nerve bridge, that's where you're having all these cells kind of basically like bridging the gap, right? They're kind of invading the damaged area, right? They're going to be removing all that extra debris, clearing out all the damaged tissues, and then forming that bridge. I'm not going to hold you guys responsible for the bands of Bunger or Bunger, but that's the term that we use for this. Right? It's going to be part of that whole entire nerve bridge. Yeah.
So I understand that macrophages come in first to clean up anything. Are fibroblasts and endothelial cells coming in simultaneously while that's happening?
Basically, yeah.
Before the Schwann cells?
Yeah. And fibroblasts are especially important for like developing connective tissues and things like that. So fibroblasts, whenever you have injury, you're gonna see fibroblasts come into play to be able to like repair the damaged tissue. And so yeah, that's all coming into play simultaneously, basically. Cool. And here's the that bridged area. So you have Schwann cells coming into play, right? So you have that bridge. This is the distal region right here, right? This is the proximal area right here. You got your Schwann cells all highlighted. They're going to be forming that scaffolding necessary to recreate that connection, recreate that bridge. And then eventually you get reformation of that peripheral connection, peripheral nerve connection. So here are some of the different biochemical processes that come into play. So you have the SOX, transcription factors, WNTs, SOX2, right, neurotrophins. So a lot of things that we actually learned already this semester, like trophic factors that allow for the regeneration of these tissues. I'm not going to test you on the transcription factors and all that for this whole process, but it involves lots of these different transcription factors. So Schwann cells. So once you get the generation of the Schwann cells, you're going to see downregulation of the proteins. That's how you get the generation of the myelin sheaths. And then the transcription factors come in to basically repair the neurons or allow for the growth cone to come into play, as well as the regeneration of new myelin sheaths. So this is These are all the mechanisms involved in peripheral nerve regeneration. And again, exercise and stimulation of the area is going to help further along this process, right? It's going to help guide this process even further. So this is an example. I think for this study they used mouse models, if I remember correctly, and they used mouse models, put them on like a treadmill, had them exercise regularly 5 days a week, and then you can see that exercise really helped to allow for regeneration of those peripheral nerves. All right. Other things that can come into play, like therapeutic interventions. So like I mentioned, you have to have the distal and the proximal portions of the neuron coming into contact. So you can basically fabricate that contact bridge, right? You can put in like biomaterials. There's going to be different types of biomaterials that you use, right, to allow for that bridge formation. They can have grooves in them to help guide axonal growth. They can have channels, fibers in them. So there's different types of devices that you could use to help guide this process along. You can also have neurotrophic factors in there, right? Growth factors that can actually help guide along the growth cone. So there's lots of things that can come into play with this. Now, with the neuromuscular junction, recall that whenever you do have nerve damage in the peripheral nerves, you're still going to have those downstream components in place. Like, for example, with the neuromuscular junction, you're still going to have that motor end plate. You're still going to have nicotinic receptors. Right? All those things are still going to be in play. And when you damage a motor nerve, you can see regeneration of those motor nerves and reinnervation of adjacent muscle fibers, right? Like whenever you have peripheral nerve damage and you're in a rehabilitation process, you're going to get new synapses forming. So it's not going to be identical to what you originally had, but they're going to be able to compensate and like allow you to have similar functionality as you did before the injury. So as you see in this diagram, so here's like the original layout. You had two motor neurons. They're innervating two different muscle fibers. As soon as you sever the nerve, maybe one of those now is going to recruit two muscle fibers. Maybe the other nerve that regenerates goes off and innervates a different muscle fiber. So you're still going to maintain similar functionality, but the orientation is going to be slightly different, right? But at least you're able to regenerate the functionality. And so here's an image that shows pre-injury versus 25 days after the injury. So they're showing like the acetylcholine receptors, right? The actual axons of the neurons. Like the layout is almost exactly identical, right? It's slightly different, but it's effectively the same thing. So you're going to be able to see regeneration of function after this type of nerve damage. So these are the types of things that are going to have to come into play with motor neurons. You're going to have ECM, which is extracellular matrix components, right? In other words, scaffolding. Neurotrophins, right? Growth factors, right? Neurotrophins are going to allow for the neurons to actually regenerate. There's going to be some other things that come into play. Low density lipoprotein receptor, as well as tyrosine kinases are going to come into play as well. Right, so this is going to allow for the motor neuron to basically find where those acetylcholine receptors are so that it can reestablish a new motor end plate. So this image is just FYI. I'm not going to test you on all these different components that are involved in reforming a motor end plate. But if you're interested, the main thing here is the acetylcholine receptor. Right, wherever the acetylcholine receptors are, that's where the motor end plate, ought to be. So with all that, you're going to have different types of affinities, right, that influence the pre- and postsynaptic cells. Here's a study where they did a graft. So they did a graft experiment. So they transplanted ganglia into a different part of the central nervous system of a guinea pig, and they were able to see different stimulation patterns, right? So if you have, for example, like a new neuron that's being grafted, right, you're going to get communication between that grafted neuron and, for example, like the like presynaptic cells, postsynaptic cells. And so there's different ways that you can see grafting stuff. I'm going to show you an image in a second where they were doing a study where they transplanted and grafted a sciatic nerve into the optic nerve pathway. And so you could see like a peripheral nerve, which is the sciatic nerve, going into a central nervous pathway where the optic nerve is. You can actually see that they're going to establish connection with each other. And so the cells are able to communicate, right, with all sorts of different types of, cell communication molecules. Right? So here's the central nervous system. Again, you're not seeing much actual repair, right? So not great in terms, at least in comparison to the peripheral nervous system. Peripheral nervous system, you can see a lot of regeneration. So these are the things that can affect the central nervous system: traumatic brain injuries, TBIs. That also includes chronic traumatic encephalopathy, right? CTE, right? Where you're having constant like injury to the brain. This especially happens with athletes, right? Football players, boxers, right? They get CTE. And over time, that starts to affect like scarring, right? I'm going to show you an image in a second, about with a football player who died at 45 years old, and he had basically the brain of an Alzheimer's patient. So CTE can really, really affect the brain, and it can basically induce early onset Alzheimer's. Also, oxygen deprivation, of course, due to like stroke, for example, and then you have neurodegenerative diseases like Parkinson's, Lewy body dementia, Alzheimer's, right? Huntington's. All those are things that can affect the central nervous system. So here's John Grimsley. John Grimsley, unfortunately, died at 45 years of age. Totally unrelated. He actually died of an accidental gunshot wound. And when they did his autopsy, they found that his brain was massively atrophied. And that's due to CTE, chronic traumatic encephalopathy. So basically what happens with CTE is you get early onset Alzheimer's. It looks a lot like Alzheimer's. You see like tau protein deposits, very similar to what you see with Alzheimer's. And again, tau proteins, that's basically what makes up like neurofibrillary tangles. So again, he died at the age 45. You see all that tau protein deposit. So this is Grimsley's brain. This is a healthy individual at 65 years of age, who obviously died. But they died at 65 years of age, and they didn't have even like remotely the amount of neurodegeneration as Grimsley did. 20 years younger. So CTE is a serious issue. So another thing that can happen too is hypoxia. You can get hypoxic. By the way, with contact sports, I know that there's been people who have advocated for, maybe putting a halt to like hardcore contact sports like, MMA, boxing, football, and whatnot. What do you guys think about that? Have you guys ever heard any of those arguments before?
They want to do it. They want to do it.
To each their own, right? Yeah, no, it's brutal. Any of you guys do any contact sports? No? If you had a kid, would you be reluctant to put them into like football or boxing or MMA? No? You would be cool with it? Yeah, even though they might get early onset Alzheimer's. Yeah. They can play flag football, right? Or wrestling. You can get some serious head injuries with wrestling, but you do wear like a helmet when you're wrestling, right? I mean, I'm a huge fan of MMA, so yeah, to each their own. So hypoxic injury. So even brief periods of hypoxia can cause neuronal damage in the CNS. What happens with hypoxic injuries is that you're seeing the apoptotic cascade come into play, right? So different types of factors will be released, even with brief hypoxia, that will induce apoptosis in the cells that are affected. You can also see autophagy come into place. Autophagy is where you have phagocytosis of cells after they undergo apoptosis, right? Apoptosis, of course, is controlled cell death, right? The cell basically is a controlled demolition, breaks apart, and then you get autophagy coming into play. So you have those cells being engulfed. And so here's an example where they did studies on a poor rat where they did a little bit of a hypoxic injury. They cut off some of the blood flow from the carotid arteries, and they wanted to see what that effect had on the rat brain. And so they did Nissl staining here, and on one side of the brain where you saw hypoxic injury, even for a brief period of time, you see reduction in neurons in those regions, right? And that's going to be due to apoptosis. And so what are the things that are involved in apoptosis? There's a lot of different mechanisms, and I'm not going to go into all of those with you guys. Just know that apoptosis happens with hypoxic injuries. But PUMA, P53 upregulated modulator apoptosis, Bax family, MOMP, there's a lot of different things that come into play with the apoptotic pathway. But the long story short is you get protein complexes resulting in caspase activity, and caspase is one of the major things that's released during apoptosis, and that's what effectively initiates the controlled demolition of these cells. Now, this is another thing that you see in the central nervous system is that scarring that happens, right? So here on the left, this is uninjured. These are uninjured regions of the brain. This is after injury. Right here, there's astrocytes. You can see the astrocytes are absolutely involved in the site of injury in the central nervous system. Same thing with the oligodendrocytes. Right? Remember oligodendrocytes, that's what produces your myelin sheaths within the central nervous system. And microglia also get heavily activated after injury within the central nervous system. And this whole entire thing is going to cause a great deal of scar tissue from showing up in the affected tissues. And here's another depiction of what's going on with this scar tissue formation. So you get a glial scars, you get all the neighboring neurons are going to start to die throughout this whole process. Right? You also get neutrophils and T-cell lymphocytes coming to play, and this all causes a lot of inflammation. Because when you get damage to the central nervous system, you also get leaky blood-brain barrier, right? Especially with like astrocytes, if they get affected, right? Astrocytes are what basically produce the blood-brain barrier. You're going to see a lot of your immune cells coming into those areas, and they're going to start creating a lot of inflammation as a consequence. And so that basically creates your astrocyte encapsulated glial scar. Right? Mature glial scar presents a major barrier to the regrowth of axons across the site of central nervous system damage. Right? So that's one of the main things that you see when you compare peripheral nerve damage to central nerve damage. This is the main thing that's differentiating those two processes, the glial scar formation. Again, this is FYI. You have lots of different ligands, receptors that come into play. You also have inhibitory signals that come into play. I'm not going to test you on any of these. These are you're not responsible for any of this, but just keep in mind that there's lots of transcription factors, lots of receptors, lots of ligands that are going to be coming into play. So here's an experiment that they did with sciatic nerve grafting. So they took the sciatic nerve, grafted it onto basically the retina, right? And so you have your optic nerve. They severed the optic nerve, and then all of a sudden the sciatic nerve was able to make the communication with the superior colliculus. And so even if you take a peripheral nerve and place it into the central nervous system, you're going to see communication between those nerves after an injury. So not exactly something that's going to be practically used in a clinical setting, at least as far as I know, but kind of interesting to see how neurons are able to communicate with each other like that. So again, here's the disruption of the blood-brain barrier, right? Once you get blood-brain barrier disruption, you get a lot of different inflammatory processes coming into play, cytokines, interleukins, right? Inflammatory markers, right? All that stuff contributes to the scar tissue formation within the central nervous system. And again, these are all the cells involved. You got your lymphocytes, right? T cells, B cells, your astrocytes, oligodendrocytes, microglia. All that comes into play and eventually forms scar tissue. Now, neurogenesis does happen a little bit, like I mentioned earlier, in the central nervous system. But for mammals, it's going to be mostly isolated to the hippocampus, right, where you're forming new memories, etc., as well as in the olfactory bulb, right, because you're basically learning about new smells throughout your entire life. And you can train those, your neurons within your olfactory bulb to be able to, catch wind of like new scents and new odors. Other animals like goldfish and birds, in goldfish grow throughout their entire life, right? They can constantly grow, especially if you put them in like an open, like a large area, right? They're going to grow really big, right? They stay smaller if you keep them confined in a small tank. But generally speaking, like in the wild, for example, they're going to grow continually. And so those neurons are going to be, there's going to be new neuronal connections, new neurons forming throughout their lives. Songbirds also are going to be developing new neuronal connections, new neurons, right? It has to do with vocalization. Here's an example of stem cells that you might find within the eyes, right? So here's within the retina. So you have retinal precursor cells, basically stem cells, that are able to form effectively most of the neurons within the retina, with the exception of cones in this case. Cones, which are the cells that receive color information. So with the exception of that, they're able to form basically all the neurons within the retina. And again, with songbirds, right, they're going to be constantly learning new songs. So acquisition, production, and perception of song, right? Super important for birds, right? That's how they communicate. That's how they attract mates, right? Speaking of which, which of the two are the ones that produce sound? Is it males or females? It's the males. Yeah, the males are trying to attract the mate. So the females, they find if they hear a song they enjoy, then they're going to, Again, in mammals, right, a little bit different. Olfactory bulb and the hippocampus. That's where you get neurogenesis, right? And don't bother yourself with the types of cells, right? Granule cells versus periglomerular cells, right? But, just be familiar with these areas, right? Olfactory bulb as well as the hippocampus. So this is FYI. I'm not going to test you guys on this stuff. Basically, you just start getting more interneurons in the olfactory bulb, right? The interneurons are the main ones that are actually regenerating, and you're getting new interneuron formation within the olfactory bulb. Okay, moving on. And then this is the sequence, right? It starts with your stem cells, and then eventually you get neuroblast, right? Neuroblast, whenever you hear blast, that's basically an immature cell, right? So a neuroblast is an immature cell that's eventually going to undergo full maturation. And here's a couple other images. So here is a neurosphere. A neurosphere effectively is a stem cell. It's a neuronal stem cell that can turn into any of these. It can turn into oligodendrocytes. It can turn into astrocytes. It can turn into neurons, right? And then these are all the areas that are involved. Sorry, the rostral migratory stream. These are all the things that are involved in there. So you got your extracellular matrix. You got your glial processes. Again, I'm not going to hold you guys accountable for all these components. Yes?
What was that cell type that you just said is?
The neurosphere?
Neurosphere, okay.
Yeah, the neurosphere is it's basically a stem cell.
Okay.
It's like a neuronal stem cell, and they can just turn into any of these in the central nervous system. Okay. Astrocytes, neuron, oligodendrocyte. Now, here are the cool studies that were done using nuclear testing. So They did autopsies. It was only on 7 individuals, but it was individuals born between 1933 and 1973. And carbon-14, that's going to be a radioactive isotope of carbon, and it's going to be a consequence of nuclear bomb testing, right? And so you started seeing a lot of carbon-14 in the atmosphere around 1955, and until about 1963. That's when they stopped doing nuclear testing. And so because of all this radioactive carbon in the environment, right, we're carbon-based creatures, right? Same thing with our central nervous system. You can see if carbon-14 was being integrated into newly formed neurons within the central nervous system. So you can actually see if there's any neurogenesis, right? If there's actually neurogenesis during the time when they were doing all this nuclear testing with carbon-14, you would see carbon-14 in those mature neurons, right? And so adult incorporation of carbon-14 in new neurons, only if there is cortical neurogenesis after 1955. If adults incorporate carbon-14 into their new neurons, born in 1955 to 1963, then that would be evidence of neurogenesis in adulthood after maturation. But these studies basically demonstrated that there actually was not any neurogenesis during those periods of time. So here's 1955. That's when you really started to see lots of carbon-14 within the atmosphere, right? After tons of nuclear testing. And you started seeing carbon-14 getting integrated into neurons of children being born, right? That's because you have neurogenesis during fetal development. So you're going to see carbon-14 being integrated in those neurons. But with adult neurons, you're not going to see any carbon-14 integration, which means that you're not getting any new neuron formation. So super interesting stuff. People born before 1955 had no cortical neurons with elevated carbon-14 levels. So basically demonstrated that there's no neurogenesis into adulthood within the central nervous system. What's up?
What kind of effect does that have on people if they have radioactive isotopes?
I have no idea. Maybe an increased level of cancer, possibly. Yeah, I mean, like with radioactive isotopes, you're going to see, because it's ionizing radiation, you're going to see more cancer development, right? Thyroid cancer is usually like one of the first ones that you would see. But I would imagine that some of these individuals would probably have a higher propensity of like brain tumors if they're getting radioactive isotopes into their brains. So, I mean, that's my presumption, but I don't know the data on that. Be something interesting to look into, though.
Yep.
Yeah, if you find anything on that, feel free to share with me.
Okay.
Non-neurons. So non-neurons, you would see carbon-14 being integrated into those cells, right? Because non-neurons are not post-mitotic, right? If it's post-mitotic, that's it. You don't get any carbon-14 integrated into those cells. So we ended right when I wanted to, around 1 hour in, so we can do our review. Let's do 2 questions here. That's all I have for you. I only made 2 questions for this section, so I'm not going to test you on a lot of this stuff, just a couple concepts. Did you find anything on that, Roy?
No, I'm going to look after that, definitely.
Yeah.
That's very interesting. Just another reason we probably shouldn't be talking to each other.
You know, yeah. I'd have to agree with you on that. I like their new circuit breakers in here. That's a nice addition to this classroom. Yeah, the duct tape. Jeez, man. What's going on, GCU? That's hilarious. So when it comes to peripheral nerve, the nervous system, right, you're going to see all these cells come into play with the exception of oligodendrocytes. Obviously, because oligodendrocytes are part of the central nervous system. But everything else is fair game. Schwann cells, macrophages, fibroblasts, and endothelial cells. Let's do one more question before we do our review. So this is a case of chronic, I keep on saying chromatic, like the chromatic scale. Chronic traumatic encephalopathy, CTE, right? So with CTE, you're going to see Alzheimer's, right? So CTE is not exactly a TBI, traumatic brain injury. It's like mini TBIs over a long period of time, right? And the accumulated effect over that long period of time is going to be early onset Alzheimer's. TBIs, CTE, they can all cause scar tissue formation as well in the central nervous system. Remember we were talking about epilepsy before spring break. People that have epilepsy, sometimes it originates from CTE or even TBIs. Concussions, too, can cause scar tissue formation. So if you had a concussion at some point in your life, like I was listening to an interview with someone who had an MRI scan done, and there was like this weird little suspicious spot, and it was scar tissue. And the individual had a concussion where they banged that one part of their head. And you can see that on MRI sometimes, if it's significant enough. And that can cause, depending on the severity of it, that can cause epilepsy in certain patients. So, any questions on any of that? All right, let's do a review session. Let's review everything for this next exam. I know it's a lot of information. So I tried to narrow it down to the really high yield stuff. So like I said, I didn't prepare a review session for you, so I'm just going to literally go through the exam and just highlight the topics that I want you guys to focus on. So give me a moment while I open that up. All right. So there's going to be a lot of diseases I'm testing on. Some are going to be psychiatric conditions. Some are going to be other types of more organic conditions that involve the central and peripheral nervous system. So some of the diseases that I really want you to be familiar with are going to be ALS, so amyotrophic lateral sclerosis, myasthenia gravis, Alzheimer's, and multiple sclerosis. So let's go into each of those. What's going on with ALS? Yeah, basically it's a degenerative disease that affects upper and lower motor neurons. It could be involving glutamate potentially. But the long story short is upper and lower motor neurons, and you're going to see the types of symptoms of both upper and motor neuron lesions, right? So upper motor neuron lesions cause what? What are some of the symptoms that you might see with an upper motor neuron lesion?
The brain.
In terms of muscle tone and reflexes. Yeah, so upper motor neuron, hyperreflexia, spastic paralysis, right? They're going to be hypertonic, basically. So their muscles are going to be, the tonicity of their muscles is going to be elevated. Versus lower motor neuron, everything is going to go down, right? So it's flaccid paralysis as well as hyporeflexia. What's going on with myasthenia gravis?
A acetylcholine.
Uh-huh.
Uptake?
No, it has to do with the actual receptors for
It
acetylcholine.
blocks that, right?
Mm,
I know it has to make receptors.
yes.
The body produces antibodies that attack.
Yes. Yes. So it's an autoimmune condition where you have antibodies binding to and destroying those nicotinic receptors at the motor end plate. And so what are the symptoms of myasthenia gravis?
The
Eyes. Yeah, absolutely. Yeah, so you're going to see amblyopia, you're going to see progressive weakness as you use your muscles. And because the extraocular eye muscles are really prone to weakness and fatigue, right, that's where you're really going to see those symptoms first. But you get that throughout the rest of the body too. You're going to see progressive fatigue throughout the course of the day, which, how do you regain the strength? Yeah, you rest. It improves with rest. Or you could take a drug like neostigmine, physostigmine, which is a cholinesterase inhibitor, so it increases the amount of acetylcholine within the neuromuscular junction. The tinsilin test, edrophonium test, that's how you diagnose it.
What did we say about acetylcholine again?
So with myasthenia gravis, it's destroying the nicotinic receptors, right? And so they're not going to respond to acetylcholine. So you can treat it using a drug that increases acetylcholine, like an acetylcholine esterase inhibitor. So neostigmine, physostigmine. The edrophonium, it's not an effective drug for treatment because it has a really short half-life. It doesn't last very long. The other drugs like neostigmine, physostigmine last longer. I forget what the half-lives are for those medications, but they are the better ones to treat myasthenia gravis. What about multiple sclerosis? Yeah, so you're seeing demyelination, right? What are some of the things you might see with a patient suffering from MS? You could see weakness. You could also get neuropathy too, right? So you're going to see, like one of the worst ones is, trigeminal neuralgia, right? Where the trigeminal nerve gets extremely sensitive and painful and irritated, right? Some people literally commit suicide because of trigeminal neuralgia. So one of the best treatments is to go in there and literally transect the neuron, right? Surgeons can do that. Also, make sure you know what some of these, like Alzheimer's, for example, multiple sclerosis, know what they look like when you see a radiograph. If you see a radiograph, be able to identify what those different conditions look like.
Do you mean like amyloid plaques?
Anything, so like CT scans, MRI scans. If you were, I don't have any histology, so I don't have any like amyloid plaque or tau protein images, so I'm not going to test you on that, but definitely know your radiographs, like neuroimaging. Know the difference between the voltage clamp method as well as the patch clamp method. What are either of those used for?
To measure the ions of the cell.
Yeah. So they both are used to study the movement of ions, right? Now, what does the voltage clamp do that the patch clamp doesn't do?
Is it just one specific cell?
It's like the opposite, right? So the patch clamp method, you're isolating one channel, basically, and you're seeing what the channel does, how it responds to different changes in the chemical composition of the substrate, right? You can see movement of sodium, potassium, etc. through just one single channel. Whereas with the patch clamp method, you're able to, first of all, control the voltage, right? You could set it to a specific voltage, and you can see what that specific voltage does in terms of movement of ions. Right? I'm not going to test you on like what happens at 55 millivolts or what happens at 0 mil. I'm not going to test you on the specific millivolts, but just know kind of like the general idea of what those types of methods are used for.
And you said the voltage clamp method is the isolation of one channel?
No, patch clamp. Voltage clamp method, you are able to establish a specific charge, right? So you could set it to like 40 millivolts and you can see what happens, like what ions move in what direction, right? And speaking of ion movement, make sure you know which ions are associated with early transient movement versus the more prolonged movement. And so sodium, what's that involved in? Like, what is that, rapid or is it longer? It's rapid. It's transient, right? Is it moving in or out? In. Potassium is what? Slower, right? And then it's going to be moving which direction? Yeah, out of the cell. Good. What is the difference between active versus passive currents?
Against the gradient, and the active is movement against the gradient. Isn't active involving energy and passive is not involving energy?
Okay, so the main thing that's going on with active movement of ions, it's going to be involving like depolarization, right? And that's specifically in a myelinated neuron, for example, that's going to be taking place where? The nodes of Ranvier. Good. Passive current and passive flow, it's not really going to be involving depolarization, but you see the flow of the ions that, they travel through the axon, right? But it's not going to affect the actual depolarization. But you get flow of ions. So in other words, active currents, depolarization, nodes of Ranvier, right? Passive currents, not involving depolarization, but it goes throughout the neuron, it goes throughout the axon. They can also,
It gets weaker, right?
yeah, it gets weaker over time. Absolutely. Yeah, whereas active currents do not get weaker over time. They propagate throughout the duration of the neuron. All right. You're going to have to know some of your receptors. So know the receptors that are involved in, for example, pain perception. Right? Do you guys remember which receptor was involved in that? So, yeah, well, nociceptors, but the ones that are more specific, or it's like, for example, heat. Yeah, the thermosensitive receptors. Know your thermosensitive receptors. They're associated with heat as well as capsaicin. Right, so make sure you know those. Okay, moving on. I know that I was going to give you guys a list of neurotoxins, but I'm not really testing you on too many of them. Just be familiar with some of the main neurotoxins that involve the potassium channel as well as the sodium channel, and how those could come into play in terms of like research purposes. So, for example, what would you do if you wanted to see what was taking place at, for example, a potassium channel, specifically in an axon?
You could use a neurotoxin to get rid of it or get rid of sodium.
Get rid of the sodium, yeah. So if you wipe out the sodium channel, for example, you could use something like tetrodotoxin, right? You use something like lidocaine, cocaine, right? Any of those cane type drugs could wipe out the sodium channel, and you could isolate the potassium channel, right?
Local anesthetics, right?
Yeah, local anesthetics. Tetrodotoxin also falls into that category as well. The main difference between tetrodotoxin and some of those other drugs, like local anesthetics that are used clinically, is that tetrodotoxin has a way longer half-life. Whereas lidocaine, it only lasts like 30 minutes, 40 minutes, 1 hour maybe at most. Right? Some people are fast metabolizers, some people are slow metabolizers, but in general, about a half an hour. Whereas tetrodotoxin, that can last the whole day. That's why people can definitely die from tetrodotoxin toxicity. What if you wanted to isolate the sodium channel? Yeah, tetraethylammonium, or TEA. So that would be an example of a compound that you could use if you want to just study specifically a sodium channel while blocking the potassium channels. Know the different types of synapses. So what are the two major types of synapses that we talked about? Yeah, exactly. So which one is faster? The electrical synapse is faster, and that's going to be involving what? Gap junctions. Absolutely. You got gap junctions that connect both neurons together, presynaptic and postsynaptic. And you get free flow of ions between those, right? What about the other type? You said chemical, right? So chemical, slower, right? So it's going to be slower. It's going to be often involving things like neurotransmitters, right, that need to bind to a receptor site. So be familiar with those. Know the process of calcium in allowing for neurotransmitter release.
You mean like second messenger?
No, sort of. So, okay, so when you have neurotransmitter release, first you have depolarization down the presynaptic cell, right? Right? So what happens after depolarization of the presynaptic cell? Yes. Yep. And so you get influx of calcium, and then you get the vesicle is going to eventually do what? It's going to bind to the presynaptic terminal, and then you eventually get release of neurotransmitters. Good. Good. What's up? Tons of different things can happen. Yeah, many things can happen after that process. But know the function of calcium and like the whole entire progression, the sequence of events. What else here? Some of the psychiatric conditions I want you to be familiar with. I want you to be familiar with all the anxiety type conditions. So what are some of those anxiety type conditions that we discussed?
GAD.
Yeah, GAD, so generalized anxiety disorder, right? There's panic disorder. I'm not going to test you guys on obsessive compulsive disorder. Bipolar is going to be part of like your mood disorders. So definitely know bipolar. So when it comes to anxiety, the big thing is knowing how to treat it. So what's one of the things that you might use to treat a patient with anxiety? You could do cognitive behavioral therapy, absolutely. But when it comes to pharmacotherapy, you could give SSRIs for an anxiety patient. Like Zoloft can help address anxiety, but other drugs would be like your anxiolytics, like benzodiazepines. And what's the mechanism of benzos? What type of receptors do they bind to? It agonizes GABA, so it stimulates GABA receptors. If you blocked GABA, then you would get neurostimulation. You would get the opposite effect. That would make the anxiety worse. Yeah. So you induce GABA, and then what happens when you have GABA activation?
It lowers threshold potential.
Mm-hmm.
By chloride ions.
Yes, chloride ions. Yeah, exactly. Good. That's really good. Okay. Definitely know bipolar 2. Bipolar 1 and bipolar 2. What are some of the characteristics of bipolar 1 disorder? 7 days of a manic episode. Yeah.
They don't feel tired after sleeping.
Yeah, they don't feel tired. They also get involved in like a lot of impulsive behaviors, right? Drugs, sex, gambling, all that stuff. Spending money. They basically ruin their lives, and it takes about 7 days, right? That's how long the manic episode lasts. Whereas bipolar 2, 4 days. So they call that hypomania. Absolutely. Let's see what else we got here. Know the 2 Clostridium toxins. So you got there's 2 Clostridium organisms that we talked about in class. Yeah, Clostridium botulinum, and the other one is Clostridium tetani. Good. What happens with Clostridium botulinum? What does that do? Flaccid paralysis. And why does it do that? It's okay. Look into it. So make sure you know how that mechanism takes place. Also know the mechanism of tetanus, right? Clostridium tetani. Spastic paralysis, know what's happening at the cellular level. So hint, both of them involve GABA as well as glycine and acetylcholine, but in different ways. Yes? Clostridium botulinum, make sure you know what happens at the cellular level. Right, with Clostridium botulinum, understand its effects on acetylcholine versus tetanus, its effects on GABA as well as glycine, right, and how those cause those symptoms that you see. Let's see, we already talked about this one. I'm not going to go over that again since we just discussed it. What's the main difference between the NMDA and the AMPA receptor?
Okay, so NMDA is blocked by magnesium.
Yes.
And AMPA, doesn't it unblock it to allow for ions to flow through?
So basically, when you have this is for like long-term potentiation, right? When you have long-term potentiation, you have enough electronic stimulation to the neuron where all of a sudden that magnesium ion gets thrown off and dislodged, right? And then that makes the cell more responsive to glutamate, right? And then as you start becoming more responsive to glutamate, you start increasing the AMPA receptors, right? And then as you increase your AMPA receptors, that's where you get long-term potentiation, right?
So the more AMPA receptors, the more...
Yeah, absolutely. So you're upregulating those AMPA receptors, which means now that that neuron is more sensitive to glutamate stimulation. So that can help with, for example, like memory processing, things like that. Know some of your psychoactive fungi. So what's going on with psilocybin?
It makes serotonin.
Yeah, so it's going to be binding to serotonergic receptors. What's the other term for a serotonergic receptor?
5-HT.
Yeah, 5-HT. Good. What's going on with Amanita muscaria mushrooms? Muscarinic receptors. You also get GABA effect, especially in lower dose. Like in higher dose amanitas, you're going to see more of that parasympathetic muscarinic activation. That's why you can actually die from ingesting too much amanitas. With low dose amanita, you're going to see more of effect involving GABA, right? And then with higher doses, you're going to see more of effect with like the muscarinic receptor, right? And know the compounds that are involved in your Amanita muscaria mushrooms. There's a question about Parkinson's disease. Right. So what's going on with Parkinson's disease? What's like the underlying mechanism of Parkinson's? The substantia nigra degenerates, right? You get reduction of what? Dopamine production. Good. So how do you treat Parkinson's patients? That's Alzheimer's. You give Alzheimer's patients things to increase acetylcholine. But for Parkinson's patients, you want to increase their dopamine. Right, so you literally give them dopamine. So L-dopa, carbidopa. But another thing that you can do is you can also do something else. Not the greatest medications out there, but
Sorry.
why don't you just give them cocaine as well? You know, they need dopamine, right? No, there's drugs that help to reduce the breakdown of dopamine. So you can give them, what's one of the enzymes that breaks down dopamine and serotonin?
MAO?
Yeah, monoamine oxidase. So you can give them a monoamine oxidase inhibitor, right? In terms of enzymes too, there's also like COMT, which is the catechol-O-methyltransferase and all that, but not super high yield. Just, monoamine oxidase, that's the enzyme. If you stop that from operating, then you're going to increase dopamine levels naturally. Those drugs are dirty drugs, though, because that's not just going to affect their brain. That's going to affect other parts of their body, too. So those have lots of side effects. That's why they're not super ideal. That's why Parkinson's is such a terrible disease, right? The L-dopa carbidopa actually only goes so far. Like there's a window period where it's actually really beneficial, but then after beyond several years of having Parkinson's, they're not really going to respond very well even to L-dopa carbidopa. It's terrible stuff. Oh yeah, no, the regions, speaking of catecholamines and other types of neurotransmitters, know the regions in the brain where you see the production of norepinephrine, production of dopamine, as well as the production of serotonin. Okay, so know those 3 different regions in the brain. Do you guys know them off the top of your head?
Don't remember.
Well, you know dopamine, right?
Substantia
nigra.
Is that norepinephrine?
Yes.
Locus
Locus coeruleus. Yeah. Which actually translates to blue region. Apparently it's blue. And then for serotonin. Yes. Good. The Raffi nucleus. Know the major differences between ionotropic and metabotropic receptors. Know some of the other effects of drugs too, like, know the effects of like cocaine, for example, like what cocaine actually does at the cellular level, how it elicits its effect. Yes, at the cellular level. Also know the effects of MDMA at the cellular level. Know the effects of caffeine at the cellular level.
Was it the caffeine blocks again?
Adenosine, yeah. That's good. Know what opioids actually do at the cellular level. What they bind to, what the effect is when they bind to those receptors. Know how they modulate pain, right?
At the cellular level, like what do they increase or
Yeah, absolutely. So like, for example, opioids, they bind to mu receptors. How do they modulate pain? They reduce substance P, right? They do a bunch of things. Right? So know those different effects. Know what's going on with schizophrenia. So we talked about schizophrenia, right? You get hallucination. You get those like positive symptoms, negative symptoms, right? Know the neurotransmitter involved in schizophrenia. It's also part of the treatment for a lot of the drugs that are used to treat schizophrenia. Yeah. Well, you don't give dopamine to schizophrenia. Yeah. That's one of the. They're mostly dopamine blockers. Yeah, which is one of the reasons why you see extrapyramidal side effects with antipsychotic drugs. Right, you can induce Parkinsonism with haloperidol, Thorazine, because those drugs produce dopamine. If you reduce dopamine, you get Parkinsonism. Right, that's one of the sad side effects of a lot of those antipsychotics.
So what are the name of these dopamine
blockers?
Yeah.
I mean, there's like haloperidol, Thorazine. Those are some of like your OG drugs. I'm not going to test you on the drugs. I can't even remember some of the more like the newer drugs. I'd have to like review those, to be honest with you. It's been a while since I touched those meds.
So what drugs are you testing this on?
Well, not the antipsychotic drugs. I'm not going to test you on like haloperidol and those types of drugs. The ones that I mentioned just now, like cocaine, MDMA, those types of drugs, you should know the mechanisms. Understand the difference between first and second messenger systems, right? So if you have like something that's hydrophilic, right, it's going to bind to a receptor that's outside the cell versus something that's hydrophobic can just like enter into the cell, right? If it's lipophilic. Know what's going on with second messenger systems as a whole, right? That involves an entire cascade inside the cell. Know the difference between your protein kinases and phosphatases, right? Know what's going on and what those do, right? I'm not going to test you on like every single one of the protein kinases. There's a lot of them, right? But just know kind of like the general, like bird's eye view of what those do. What else we got here? Sorry, there's a few here that I'm skipping over because we basically already talked about it. Know what's going on with your mood disorders. So we talked about bipolar already. Know what's going on with depression, right? Know what type of neurotransmitters might be involved in depression. It's not a hint. It's not just serotonin, because depression is it's a complex phenomenon. It involves lots of different things. So serotonin is just a little tiny piece of the puzzle. There's other neurotransmitters involved as well. Recall the studies that were done using the sea slug, right, with like habituation as well as sensitization, right? Know how you induce habituation. Know how you induce sensitization. Right? Remember, there's going to be a couple studies that were involved in that, right? So those, for example, with sensitization, involved like certain interneurons, as an example, where they were like stimulating the snail in different parts of the body. Right? Same thing with habituation, right? Be familiar with those overall processes.
By saying that, do you mean at like the cellular level or like something like glabellar tap?
That too. Know the glabellar tap test. Yeah, that's going to be important for Parkinson's patients, right? And so the glabellar tap test is going to be an example of what?
Habituation.
No, it's actually the opposite. It's a constant sensitization, right? Because they're constantly reacting to it, right? Whereas any of us in this room, after about 2 taps or so, they're like, okay, your eyes stay open, right? Because that's habituation. You became habituated to that sensation. Know what's going on with alcohol withdrawals. Okay, so know why you see alcohol withdrawal symptoms. Know your seizures. So you have 4 major types of seizures that we talked about in this class. Do you guys remember them?
Petit mal, grand mal.
Good. Those fall under what category? Generalized seizures. Now, what about the partial ones?
Simple partial is absence. Isn't that?
Absence is petit mal. Yeah. So grand mal, that's going to be your tonic-clonic, right? Petit mal is also known as absence seizure. Now you have simple partial and complex partial. Now, what's one of the major differences between your simple partial and a petit mal seizure? Don't they look almost very similar? Yeah, absolutely. That's one of the major differences, right? Because one's generalized and one's not. One's partial. And how long do they last? The petit mal versus simple partial.
It's a couple minutes, or simple partial is a couple seconds.
Yeah, like 10 to 20 seconds.
1 to 2 minutes.
Yes, complex partial, like around 1.5 minutes, 2 minutes or so. Complex partial, simple partial, do you get post-ictal confusion? No. Do they lose consciousness? No. Good. What about complex partial? Do you get post-ictal confusion? Yes. Right? Now, what about tonic-clonic seizures? What's going on with that?
You have the 4 different phases.
Yes. What are the 4 different phases?
The aura.
Prodrome, which lasts sometimes over a day. Then you have the aura, which right before, which is characterized by what? What do you get during the aura? Hallucinations, smells, sounds, tastes. Then you get the, which is called, the ictal phase, which involves tonic and then clonic. What happens during the tonic phase? They seize up, they stiffen, right? They become rigid. Clonic phase, they start like uncontrollably jerking. So that's good. You guys know those different symptoms. Know what is involved in ADHD, attention deficit hyperactivity disorder, right? In terms of, symptoms, but also in terms of neurodevelopment, right? There's a couple things that happen with those individuals while they're developing from a young age. It has to do with gray matter development, okay?
Don't they develop less gray matter?
Basically. They also get, in terms of like synaptic pruning, it happens prematurely, right? So generally speaking, you have the most synapses when you're about like 2-5 years of age, like and during early adolescence. And as you develop over the years, you start losing synaptic connections, which is totally normal, part of like neurodevelopment. So ADHD patients have different types of neural development. Be familiar with strabismus. Strabismus, what it can do if left untreated. What are the treatment options for strabismus? Be familiar with the monocular deprivation studies, right? And also be familiar with critical periods. I'm not going to test you on like those specific times, right? That's like a lot, right? I'm not going to say, oh, when does like language develop? When does eyesight develop, right? I'm not going to ask you about specific times, but just understand like the general concept behind what a critical period is. A time during which you have like important development, that if you don't meet those developmental milestones during that specific period of time, you are forever going to have deficits in those areas. So understand that concept and understand Wallerian degeneration, and that's it. Do you have any questions? Wallerian degeneration. So peripheral nerve damage and repair. That's all of it. You guys have any other specific questions?
Critical period has to do with like the eye study.
Eye studies, speech, like lots of things. Even like socialization, like learning how to socialize with people. Critical periods define everything in your entire existence neurologically, right? Special senses, right? They have to develop during a specific time, and they require external stimulus to be able to develop properly. Like if you deprive vision during a critical period, you're going to be blind in that part of the eye, right? If you deprive social interaction to a young individual during their critical period, they're going to forever be developmentally challenged, right? In terms of like social interactions.